Our last speaker in this section is Peter Maloca. He currently works as an associate professor and group leader ophthalmic imaging at the Institute of Molecular and Clinical Ophthalmology, Basel, and as a research fellow at the Moorfield Eye Hospital NHS Foundation Trust. His group is focused on cutting-edge imaging techniques for macular degeneration, glaucoma, diabetic retinopathy, eye tumors, digital reality, and artificial intelligence. His group research program develops methods for imaging the human eye with an emphasis on optical coherence tomography and multiphoton laser microscopy. Furthermore, Dr. Maloca is board member of the organization EMERSOC and founder of the Spectrum Foundation. Thank you for your presence, Peter, and the floor is yours.
Thank you so much. First of all, do you have a visual and an audio from my slides? Yes. Okay, so I will talk about the clinical settings for ophthalmological readouts. And thank you so much for the organizing of this event. These are my interests. So before I start with the imaging, I would shortly introduce a general question. What are the targets for our imaging? Is it only the anterior part of the eye? Or is it just the posterior part? And of the posterior part, is it only the macula? And what is with Rome? Rome is rest of the macula. And I think it's very important to understand that we look only at a very, very small part of the eye and also of the optic disc. So we have a narrow window, and that narrow window is very important for imaging. So how do we get to the signals? Through the pupil, through the lens, through the vitreous, to the topic what we want to image. And how do we obtain the worst readouts? So please, it's very important to be very careful when you do clinical imaging or also with animals. This patient was really difficult to image because he has a very small lid opening, and then you can use a speculum to open the eyes. I prefer these ones because the eyelashes are also separated from the opening. Look here. A small pupil is really hard to get images of the retina or signals. So here you can darken the room or widen the pupil with eye drops. Then there are features of the eye. So when you have an astigmatism like this patient, it's really hard to get nice images from the retina. So the imaging and readouts starts before getting to the retina. And here you can use contact lenses. And a very important point is dry eye. When you are treating your animals for half an hour or 1 hour, it's very important that the eyes are very lubricated. So look, these green spots, this is a dry eye. And when you have such a situation, you will always get bad images and loss of image quality. And this patient, where is the problem? Of course, right eye is okay. I did a cataract surgery, but on the left eye, he has a white cataract. Also in animals, they may develop a cataract and you won't get really nice images. Like this cataract of a patient of mine. And look here, one eye, I did the surgery on the left side and the right eye has a cataract. So I will get much better images for the left eye than compared to the other eye. And this is very important when we start to talk about the imaging technologies. The first of all is the color fundus imaging. People think color fundus imaging is old age, but I think it's very important to document the retina, and it's important to share the images also with the patient. Normally, for this color fundus imaging, you use all the spectrum of the light. So this is a patient of mine who had a maculopathy in the center, and you see there a modeling of the macula. So this is color classic imaging. Then you have the chance to use two different color of laser and make a so-called composite image. It looks like a real color fundus imaging, but it's not. It's a laser generated image which has advantages but also disadvantages. So when we go to the deeper level, what maybe be more of interest for you is the display of accumulated pigments such as lipofuscin inside the RPE cell. What you see here, these are the yellow dots. Lipofuscin is very important also for the clinical setting, and you know this is very important in situations with age-related macular degeneration or other diseases. So in number 4 we have a lot of this accumulated lipofuscin, and then we can use an imaging called autofluorescence, where we can display this pigment. Here is a normal eye, a patient suffering from Stargardt in an early stage, and this here you see in the late stage, there in the center where the pigment is lost, it's dark. The next technology is a cross-sectional technology. And in that situation, we use a laser like this. Of course, you can use different laser colors, but what is important when you use a laser, it is that the waves are coherent. And because they are coherent, it's hot. So you will destroy the tissue, what you are imaging, when you are not very careful. One adaptation of such a technology is that we swipe with the laser over the retina, and we call that a scanning laser ophthalmoscopy. In the first glimpse, you see here a scanning laser ophthalmoscopy of the posterior fundus of my patient suffering from age-related macular degeneration. The whitish spots are drusen, so-called drusen accumulation of debris. It looks like a fundus image, but also is a computer-generated image. And this is very important because this SLO imaging is the basis for further imaging in cross-section. When we adapt the laser source to a short pulse, we also can image the retina. In this situation, we have a cutting with laser, and because the energy is only very short, we have no damage of the tissue, and we call that optical coherence tomography. Of course, the cross-section is very interesting. Here you see then the compartments of vitreous, retina, and choroid. And this is a normal, healthy human eye. In that patient, we use the SLO as a general overview system. And then we make at the green line on the left side the cross-section, and then on the right side you have the cross-sectional imaging of age-related macular degeneration. This case is a normal eye. You see all the layers in a normal display, and maybe you know what this could be. In the normal eye, you see this depression. So I call that the Maloca depression because it makes me always happy. And this is the macula. It's a foveolar depression. And this is the only depression that makes me really happy. In the lower image, you see the depression is really huge and we have an atrophy. And the RPE has gone. So we have a visual on the choroid, and the choroid is really thick. And this patient is suffering from morbus Stargardt. So the cross-sectional imaging with OCT is giving you structural information, not cellular, but structure of every layer, also of the choroid. In this patient, you see a color fundus image of the optic disc and the macula in the center. It's not an ape, it's a human man, you see. The optic disc is orange, it's normal. And look here, the top level is his cross-sectional imaging with a nice fovea depression. The outer lines of the retina are also visible. In the first look from the lower images, you think, well, that's a normal eye as well, but it's not. The lower image is his son, and he had only a visual acuity about 30%. He has learned in the recent years to live with that, but he has a severe disease of the eye. The top representation is a 3D rendering of the thickness of the eye. A normal macula looks like a volcano in this 3D rendering. And you see in the lower picture, first of all, a widening of the foveolar depression, what I told you. I'm not happy because it's too wide. And you see also the green color has diminished. So we have a loss of the thickness of the retina. He was not aware of that, but I was knowing his mother, and I was forcing him to come for a visit. He didn't want to have a check, and his mother had just the same situation. And this was then finally, after gene analysis, we had the rod cone dystrophy in the mother and the son. Here again, top level was the father, and the lower you see the optic disc, which is pale, and the macula, which is not normal. So we use different possibilities to image the eye, and not one will give you the answer, but sometimes you need several ones. So this was imaging of the structure. Now we go to the cellular level using adaptive optics. This is coming from the military research where they use the laser light to correct images like the Uranus, and then you see much a nicer picture. So this is really an advantage, and we can apply that also for the eye. So these are the waves. They are passing the eye, and there are aberrations. And these aberrations in phase and wave are then corrected to get a much better image. And we call these wavefronts, as you see here. The system very easily displayed are three elements. First of all, when you look here, we have a wavefront sensor, and then we have a computer that is in real time looking for these signals. And then you have a mirror, and this mirror is deformable. And with that deformable mirror, we can correct the signal. And then you will get images of the eye. In this case, we used YesLO as a basis in a resolution like this. And then we have layers. But with such a machine, we see then on a cellular level also the mosaic. And this is, I think, the most interesting part for you. And the resolution, of course, is much higher. And we see now cells. But in a clinical setting, it's really difficult. Here you have a panoramic view of the eye, and the small squares are really the field of view what you will get with such an imaging. It's really small. And I will show you some examples now when we have here the vessels. This is the optic disc here. And when you look with adaptive optics, it's this here. So you see the nerves and also the vessels. You can calculate the thickness of the vessels, and I think it's very important that we also check the vessels, not only the cells. When you look at the optic disc here, you see the superficial part, but also the lamina cribrosa. So it's very interesting to see these elements. When we go further to the periphery, you see these vessels and also the mosaic, which is nicely displayed in the periphery, but not in the fovea, because there you have very crowded situations. Today we have analyzers to quantify also these cells. And when you see here that case, this is a geographic atrophy where we lose the RPE, and the lines is the progression of the disease over the time. Here we have a patient who was suffering from chloroquine medication, and you see this mottling of the pigment, so there is a loss of the nice mosaic. In glaucoma, it's also interesting, but it's not clinically used. You see here the excavation of the optic disc. In diabetes, the small spots are the elongation of the small vessels we call aneurysms. So this is a very typical finding in diabetic retinopathy in the lower image. So these are the modalities, and I will show you only some images. I'm very thankful to Marine Durand and Laurent Vabre, who have provided me with some images from the clinical setting. So there are many diseases which can be detected on a cellular level, new features. And so we see that in some cases on the right side, you see the cones disappear, you will get the blurred images, and then the pattern is disorganized, and there are really nice images to learn from. So in a patient having no issues, but suffering from choroidal dystrophy, you see here this disappearance of the cones in these areas, and it's a blurred area then. In MACTEL2, this is a neurodegenerative disease. You see also that the cones are disappearing, and you will get a parafoveal blurred area. Then in occult macular dystrophy, there is a so-called star night cone pattern. It's dark, and then you see small signals from the cone receptors that have survived. In bestrophinopathy, you see also the cone mosaic has vanished, and you see these parafoveal areas with these distinctive lesions. So it's very useful on the cellular level to have this machine. There are also lesions in a larger area, not on the cellular level, but on the structural. So you see here in autosomal dominant optic atrophy, these very strange cystic areas, these roundish areas. And in foveoschisis, you see also this arrangement, which is very typical for this disease. So we are also able to now count the cells in this study, was published. So we have a quantification. And I'm also very happy now for Leber that we have a therapy. And you see in a short time that with adaptive optics, you will see a change in a short time of these receptors. Only after 3 months, we have an effect in these individuals. So limits, you need a large pupil. Tracking is sometimes difficult. It's not an easy to use machine, and the foveal cones are hard to display. The credits go now to these collaborators who have contributed with these images, and also a big thank you to Imagine Eyes who have helped to prepare these slides. Upcoming technology is this machine that also includes all types what I have shown you. So this is a really nice image of an SLO with an OCT, but also the vessels can be displayed. But more, we can use this machine also for the single cell imaging and the enhanced OCT imaging, but also for the vessel display. What I think is very important to calculate also what is changing there. So thank you so much for your kind interest. And I hope that I have shown you some clinical settings where we use this imaging.
Peter, thank you for your presentation. It was really insightful, and I have to say it has to take a trained eye to recognize all of these images in detail that you just showed us. I wonder if there's any urgent questions right now, but if not, maybe we can take the discussion into one of the spatial chat rooms where the participants can talk to the guests if they have any questions. No, then I would want to thank you, Peter.